Welcome back to the deep dive. Today we are looking at something that honestly feels like a paradox of our own biology. We're looking at the engineering schematics of the human stomach.
It's a fascinating and, slightly unnerving topic. We all walk around with this biological containment vessel inside of us.
Right, and it's holding a chemical hydrochloric acid that is essentially an industrial solvent.
It really is. I mean, we're talking about a chemical that's corrosive enough to dissolve metal, like zinc.
And the pH can drop to, what, below 1.0? That's not just sour, it's designed to denature proteins on contact.
Exactly. And the paradox you mentioned is that the container itself, the stomach wall, is made of meat. It's made of the very proteins that acid is built to destroy.
So the central question, and this is really the core of Goodman and Gilman chapter 49, isn't just how do we digest food,
It's how do we not digest ourselves?
Yeah.
That's the fundamental problem that gastric physiology and pharmacology have to solve.
And when that containment fails, we're not just talking about indigestion. We're talking about what you could call the pharmacology of controlled corrosion.
A perfect way to put it.
So today, we're breaking down that system. We're going to look at the acid factory itself, the parietal cell, the triple threat signaling system that drives it, and then, of course, the drugs we use to hack that system.
Right. Everything from a simple antacid all the way up to the molecular siege engine that is the proton pump inhibitor, or PPI.
For this deep dive, we're synthesizing two core texts. We have the clinical framework from Katzing and Trevor's Basic and Clinical Pharmacology, that's chapter 62.
And for the deep molecular mechanisms, the why behind it all, we're leaning heavily on Goodman and Gilman's The Pharmacological Basis of Therapeutics, chapter 49.
And our usual disclaimer applies here. Think of this as a conceptual map. We are giving you the lay of the land, the key landmark, so that when you go to read these chapters,
You absolutely should read them.
you know where you are and what to look for. We're preparing you for the reading, not replacing it.
It's the architectural tour before you study the blueprints.
Okay, so let's start with those blueprints. The acid factory itself, the parietal cell. This isn't just any old cell in the stomach lining, is it?
Not at all. It's a high-performance, high-energy machine. Goodman and Gilman make a really important point about its structure. If you look at it under an electron microscope, it is absolutely packed to the gills with mitochondria. It has one of the highest mitochondrial densities of any cell in the body.
Which is on par with, what, cardiac muscle?
You could argue it rivals cardiac muscle, yes. And that density tells you something immediately.
It's doing an immense amount of work. It needs a ton of energy.
A staggering amount of energy.
Yeah.
And that's because it's generating the largest known ion gradient in any vertebrate.
Okay, let's put some numbers on that because that sounds impressive.
It is. The pH inside the cell, in the cytoplasm, is about 7.3, basically neutral.
Right.
The pH inside the canalicculus, this tiny little channel where the acid is actually secreted, is around 0.8.
0.8. So from 7.3 to 0.8. That's a concentration difference of
What is that?
over a millionfold.
More than 1,000,000 to 1 gradient, and it's doing that across a single cell membrane.
So you're trying to push a hydrogen ion, a proton, against a concentration gradient that steep. That's the work.
That is the work. It's the molecular equivalent of pushing a boulder up a vertical cliff face. It requires massive, massive amounts of ATP.
And the engine doing all of that pushing is the H plus K plus ATPase, the proton pump.
This is the star of the show. It's the final common pathway for acid secretion. It's a P-type ATPase, which means it phosphorylates itself during its cycle. It's a cousin to the sodium-potassium pump that runs your nerves, but it's, let's just say it's on a whole other level.
So walk us through that cycle. How does it physically move a proton from inside the cell to outside?
Okay, so imagine a revolving door. The pump, in its first state, call it E1, is open to the inside of the cell. It binds a hydrogen ion. Then ATP comes along and donates a phosphate group.
It gets phosphorylated.
Right. And that phosphorylation is like a jolt of energy that forces the protein to change its shape. The revolving door snaps shut on the inside and opens to the outside, into that acidic canalicculus.
Well, it literally squeezes the proton out into the stomach lumen.
It exposes it to the acidic exterior, and at the same time, it lowers its own binding affinity for the proton, so the proton gets ejected. But the cycle isn't done.
It has to reset.
Just to reset. To do that, it grabs a potassium ion, a K plus air, from the outside. Binding that potassium triggers the pump to dephosphorylate, to lose that phosphate group, which causes it to snap back to its original shape, open to the inside again.
And it drags potassium in with it.
Exactly. One proton out, one potassium in. It's an electroneutral exchange.
Okay, but here's a key point, and I know this is vital for the pharmacology later. The pump isn't just sitting on the cell surface all the time, is it?
No, absolutely not. That would be incredibly wasteful. When the parietal cell is resting, when you haven't eaten for a while, most of these pumps are held in reserve. They're stored inside the cell in these little membrane sacs called tubulovesicles.
So they're in the barracks, waiting for the call to action.
Precisely. They are dormant and not part of the active membrane. When a signal comes to secrete acid, these vesicles are signaled to move to the surface and fuse with the canalicular membrane.
And that fusion dramatically increases the surface area and puts all these pumps to work.
It's a massive recruitment. And understanding that recruitment process is the absolute key to understanding why we tell patients to take their PPIs at a very specific time.
We will definitely circle back to that because it's a huge clinical point. So the pumps are in the barracks. Who sounds the alarm? Who tells them to get to the front lines?
This is where we get to what I like to call the three whistles. The regulation of acid secretion is intentionally redundant. Evolution did not want you to miss a meal, so it built three separate, overlapping pathways to make sure digestion happens.
You've got the neural pathway, the hormonal pathway, and the paracrine pathway.
Correct. Let's start with the neural one, acetylcholine.
This is the vagus nerve, right? The classic cephalic phase of digestion.
Exactly. You see a delicious meal, you smell something baking, you even just think about food. Your brain sends a signal down the vagus nerve. At the end of that nerve, it releases acetylcholine, which binds to the M3 muscarinic receptor on the side of the parietal cell.
Okay, so M3 receptor, but let's go deeper. What happens inside the cell? Stimulation is too vague for this deep dive.
You're right. We need the pathway because the drugs target the pathways. The M3 receptor is a G protein coupled receptor, a GPCR. Specifically, it's linked to a GQ protein.
GQ. So that means it activates phospholipase C.
You got it. Phospholipase C cleaves a membrane lipid to generate two second messengers, IP3, inositol trisphosphate, and DS, diacylglycerol.
And IP3 is the key here. It goes to the endoplasmic reticulum and
It opens the calcium channels. It causes a massive release of stored intracellular calcium. That spike in calcium is the go signal. It tells the tubulovesicles to fuse with the membrane and deploy the pumps.
Okay, so that's pathway number one. Acetylcholine, acting via the GQ calcium pathway. What's the second whistle?
The second is gastrin. This is the endocrine or hormonal signal.
So this is coming from the blood.
Right. When food, especially protein, enters the stomach, specialized G cells in the antrum, the lower part of the stomach, release the hormone gastrin into the bloodstream.
And it circulates through the body and comes back to the stomach.
And it comes back and binds to its own receptor on the parietal cell, which is called the CCK2 receptor.
And is CCK2 also a GPCR?
It is. And fascinatingly, it uses the exact same intracellular machinery as acetylcholine. It's also a GQ-coupled receptor.
So it also activates phospholipase C and raises intracellular calcium.
Exactly. So now we have two distinct signals, one from the brain and one from the stomach itself, both shouting the same message inside the cell. More calcium.
Okay, so that's two signals, same pathway. But then there's the third whistle, the paracrine one.
And this is, in many ways, the most important one, histamine.
And this is where the signaling pathway inside the cell finally diverges.
It does. Histamine isn't a hormone or a neurotransmitter in this context. It's a paracrine signal, meaning it's released by a neighboring cell and just diffuses a short distance.
It's released by the enterochromaffin-like cells, or ECL cells.
Right, which sit right next to the parietal cells. When the ECL cells are stimulated, they release histamine, and it binds to the H2 receptor on the parietal cell.
The H2 receptor, this is not the H1 receptor that causes allergies, a totally different target.
Totally different. And the H2 receptor is not coupled to GQ. It's coupled to Gs.
G's for stimulatory.
Right. GS activates an enzyme called adenyl cyclase. Adenyl cyclase takes ATP and converts it into cyclic AMP, or HANCAMP.
A different second messenger.
A different second messenger. That CMP then activates another enzyme called protein kinase A, or pKa. And it's pKa that does the final work of phosphorylating the proteins that are involved in moving those pumps to the membrane.
This distinction, the calcium pathway versus the CANAP pathway, this is what allows for what Katzung calls potentiation, isn't it?
This is perhaps the most important concept in regulating gastric acid. It explains so much about the pharmacology.
So potentiation means the whole is greater than the sum of its parts.
Much greater. If you stimulate the cell with just acetylcholine, you get, let's say, 1 unit of acid. If you stimulate it with just histamine, you get 1 unit of acid. But if you hit the cell with both acetylcholine and histamine at the same time...
You don't get 2 units, you get like 10 units.
Exactly. The calcium pathway and the CMP pathway talk to each other. They cross-amplify. The effect is synergistic, not just additive.
Which explains why just blocking one of those pathways, say with an H2 blocker for histamine, doesn't shut down acid production completely.
Not even close. You remove that powerful multiplier effect. But the other signals, acetylcholine and gastrin, can still push the system forward through the calcium pathway.
So the system is not only redundant, it's synergistic.
And there's one more layer of complexity here that's crucial. Gastrin, that hormone from the G cells, doesn't just stimulate the parietal cell directly.
It has another target.
Its main target, arguably, is the ECL cell. Gastrin is the most powerful signal telling the ECL cell to release histamine.
So gastrin is a double agent. It pulls the calcium trigger on the parietal cell directly, but it also calls in the heavy artillery by telling the ECL cell to dump a ton of histamine.
Which then activates the CAMP pathway and potentiates the whole system. It's an incredibly powerful positive feedback loop.
Okay, that system seems designed for maximum aggression. If it's built to amplify itself like that, there has to be a break. There has to be an off switch.
Of course. You can't have a runaway reaction. The primary break is a substance called somatostatin.
Somatostatin is released by D cells.
Right. Think of the D cells as the stomach's acid sensors. They sit right there in the stomach lining, and when the luminal pH drops too low, usually when it gets below 3.0, the D cells are directly stimulated by the acid. They get irritated by the acid. And in response, they release somatostatin. And somatostatin is the universal off signal in the GI tract. It's the wet blanket on the fire.
So it tells the G cells to stop making gastrin.
It directly inhibits gastrin release from G cells. It also inhibits histamine release from ECL cells. And it even has a direct inhibitory effect on the parietal cell itself. It shuts the whole system down.
So it's a classic negative feedback loop. Acid gets too high, D cells release somatostatin turns off the acid production.
A beautiful, elegant feedback loop.
Unless, of course, something comes along and sabotages the D cells.
Now we've arrived at Helicobacter pylori.
We're going to break down the full clinical picture of H. pylori later, but just mechanistically, what does it do to this feedback loop?
H. pylori sets up shop in the stomach and creates a chronic inflammatory environment. This inflammation specifically damages and impairs the function of the D cells.
It takes out the brakes.
It cuts the brake lines, so you lose that negative feedback. The G cells are no longer being told to shut up, so they think the stomach isn't acidic enough. They start pumping out more and more gastrin.
Which leads to hypergastrinemia, which leads to more histamine, which leads to more acid.
And you get hyperacidity that's paradoxically caused by a bacterial infection that has disabled the normal off switch. It's brilliant biological hacking by the bacteria.
Incredible. Okay, so we've mapped out the aggressive factors, acid, pepsin, the three whistles. But the stomach isn't just an acid bag. As we said, it's a defended fortress. Let's talk about mucosal defense.
This is a system that is just as complex and important as the acid secretion system. We tend to take it for granted until it fails.
And it's not one thing, it's a multi-layered shield.
Multiple layers. The first and most obvious is the mucus bicarbonate barrier.
Okay, break that down.
The epithelial cells on the very surface of the stomach lining do two things. First, they secrete a thick, viscous, adherent mucus gel. It's like a layer of slime that physically clings to the surface.
Right.
But at the same time, they're actively secreting bicarbonate HCO3 into that mucus layer.
Yeah.
And the bicarbonate gets trapped in that sticky gel.
Creating what some refers to as the unstirred water layer.
Exactly. And what this does is it creates a stunning pH gradient across a very, very short distance, maybe 0.2 millimeter.
So on the stomach lumen side of that gel, the pH is 1 to 2.
Corrosive. But at the actual surface of the epithelial cells, underneath that mucus bicarbonate layer, the pH is maintained at a perfect 7.0. It's neutral.
That is an unbelievable engineering feat. A 100,000-fold difference in acidity across the thickness of a few sheets of paper.
It's astounding. But it relies on one critical factor that we have to emphasize for anyone listening.
Blood flow.
Blood flow. You cannot maintain this defensive barrier without robust perfusion. The bloodstream is what delivers the raw materials for bicarbonate. It delivers oxygen for the cells to function, and it's what washes away any hydrogen ions that manage to back diffuse through the mucus.
Which brings us directly to the concept of stress ulcers in critically ill patients. It's not emotional stress.
Not at all. It's physiological stress. In a patient with major trauma, severe burns, or septic shock, the body's priority is to send blood to the brain and the heart.
It shunts blood away from the gut. The stomach is considered non-essential for immediate survival.
Right. And when that blood flow drops, the mucosal defense shield collapses. You can't make mucus or bicarbonate. And normal levels of acid, which were fine a minute ago, now start to eat right through the stomach wall. It's a plumbing failure.
Okay, so if this defense system is so critical, there must be a master regulator for it, just like there is for acid.
There is. The conductors of the defensive orchestra are the prostaglandins.
Specifically PG2 and PGI2.
Right. These are local signaling molecules derived from fatty acids, and they do everything you would want for defense. They bind to their EP3 receptors on various cells.
And what do?
They do 4 key things. 1, they stimulate mucus secretion. 2, they stimulate bicarbonate secretion. 3, they cause vasodilation, increasing that critical blood flow. And 4, they have a direct inhibitory effect on the parietal cell, turning down acid production.
So they simultaneously build up the shield and turn down the assault. They're the peacekeepers.
They are the peacekeepers. And this leads us directly to the single most common way that we, as physicians and patients, accidentally destroy this defense system.
With NSAIDs?
Non-steroidal anti-inflammatory drugs. Aspirin, ibuprofen, naproxen. Billions of doses are taken every year.
And to understand how they cause ulcers, we need to be a little nuanced about the enzyme they block. Cyclooxygenase or COX.
Right, because there are 2 major forms of the COX enzyme, COX-1 and COX-2.
And they have very different jobs.
Very different. COX-1 is what we call constitutive. It's on all the time in many tissues doing normal housekeeping functions. In the stomach, COX-1 is the enzyme that makes those protective peacekeeping prostaglandins.
Okay, so COX-1 is the good guy, at least in the stomach.
In the stomach, yes. TOX-2, on the other hand, is the inducible enzyme. It's normally at very low levels, but its production gets ramped up dramatically at sites of inflammation. It's the one that generates the prostaglandins that cause pain, fever, and swelling.
So in an ideal world, if you have arthritis, you'd want a drug that only blocks the inflammatory COX-2 and leaves the protective COX-1 in the stomach completely alone.
That was the dream. That was the rationale behind the entire class of COX-2 selective inhibitors. But the traditional NSAIDs that you buy over-the-counter, ibuprofen, naproxen, they're non-selective.
They're a carpet bomb. They hit both enzymes equally.
Exactly. So you take an ibuprofen for your headache, and yes, you block COX-2 and the headache gets better, but you are simultaneously blocking COX-1 in your stomach.
You're firing the peacekeepers.
You've just stripped the stomach of its protective prostaglandins. And without them, mucus production drops, bicarbonate secretion drops, blood flow constricts, and acid secretion actually goes up a bit. You've left the fortress completely vulnerable.
And this is why the coxib drugs, like celecoxib, were developed. They were designed to be snipers that only hit COX-2.
And from a GI perspective, they are much safer. They cause significantly fewer ulcers and bleeding events than traditional NSAIDs.
But as we famously learned with the Vioxx scandal, there's always a trade-off.
There is no free lunch in pharmacology. It turned out that COX-2 also plays a role in the balance of clotting and anti-clotting factors in our blood vessels. By selectively blocking it, you tip the scales towards thrombosis.
So you save the stomach, but you risk a heart attack or a stroke.
A classic, and in that case, tragic pharmacological trade-off. It highlights just how interconnected these systems really are.
Okay, this is a perfect pivot point. We've mapped the battlefield, the aggressive factors, and the defensive factors. Now, let's look at the weapons we use to intervene. The pharmacology of acid suppression. Let's start with the oldest and simplest tool, antacids.
The fire extinguishers. Simple, straightforward chemistry. Acid plus a weak base equals salt and water.
It sounds almost primitive compared to what we're going to talk about next, but in terms of speed, they're still the fastest, aren't they?
Absolutely. The benefit is immediate relief. You have heartburn, you chew a Tums, the neutralization happens instantly. But the devil is in the details of the chemistry. The specific base you use dictates the side effect profile.
Let's compare the big ones. Sodium bicarbonate or baking soda.
Very fast, very effective. But the chemical reaction produces carbon dioxide gas, CO2.
Which means belching and bloating.
Right. And, more importantly, it's a huge load of sodium. If you have a patient with heart failure or hypertension or kidney disease, giving them that much salt is a terrible idea.
Okay, what about calcium carbonate, like in Tums?
Also very fast. Also produces CO2 gas. You get the belching. But the bigger concern here is the calcium.
Hypercalcemia?
If used excessively, yes. And it can lead to a condition called milk alkali syndrome, especially if taken with dairy. You get high calcium, alkalosis, and acute kidney injury. It's rare, but we see it.
So that brings us to the more common liquid antacids, the ones based on magnesium and aluminum hydroxides.
Right. The benefit here is that their reaction with acid does not produce gas. So less bloating, but they have their own opposing problems.
The classic mag versus al issue.
Exactly. Magnesium salts are poorly absorbed and act as an osmotic laxative. They pull water into the gut. So milk of magnesia causes diarrhea.
And aluminum does the opposite.
Aluminum salts cause constipation. They relax the smooth muscle of the gut and delay gastric emptying.
Which is precisely why products like Maalox or Mylanta combine them. It's not a random combination.
It's a brilliant bit of formulation. They use the diarrhea-causing magnesium to cancel out the constipation-causing aluminum. The goal is to get a normal bowel movement, a pharmacological balancing act in a bottle.
One more key point on antacids, drug interactions.
Crucial. They do two things. First, by raising the stomach pH, they can affect the absorption of other drugs that need an acidic environment, like ketoconazole or iron supplements.
And second,
they can directly bind to other drugs in the stomach. This is called chelation. They can grab onto antibiotics like tetracyclines or fluoroquinolones and prevent them from ever being absorbed.
So the clinical rule is to separate antacids from other medications by at least 2 hours.
At least 2 hours.
Okay, let's climb the ladder of potency, the next class up, the H2 receptor antagonists, the kelotidines.
Right. Cimetidine, which was the first blockbuster drug in history, ranitidine, famotidine, these changed the world of gastroenterology.
Before these drugs, a patient with a severe peptic ulcer was facing surgery.
Often a vagotomy, where they literally cut the vagus nerve, or even a partial gastrectomy. These drugs saved millions of people from the knife.
And mechanistically, they are competitive antagonists at the H2 receptor.
Correct. They sit in the histamine parking spot on the parietal cell and prevent histamine from binding. By doing that, they shut down the GCMP pathway.
But going back to our potentiation concept,
they're imperfect. They effectively take out the histamine leg of the three-legged stool. And since histamine is the dominant driver of basal and nocturnal acid secretion,
they're very good for nighttime heartburn.
Excellent for nocturnal acid.
Yeah.
But during the day when you eat a meal, the other two signals acetylcholine from the vagus nerve and gastrin can still stimulate the cell through that calcium pathway.
So they're less effective against meal-stimulated acid.
Much less. Overall, they reduce 24-hour acid secretion by about 60 to 70%. Which is good, but it leaves a fair amount of acid on the table.
And the other major limitation is tolerance.
Tachyphylaxis. This is a huge issue. The body is smart, it notices the histamine blockade, and within just a few days, it starts to compensate.
How does it do that?
The body upregulates other pathways. Gastrin levels start to rise to try and overpower the blockade. The effect of the drug starts to fade within 3 to 5 days of continuous use.
So they're better for on-demand use rather than scheduled daily therapy.
For many patients, yes.
We also have to talk specifically about the first-generation drug, cimetidine. It has a bit of a reputation.
It's a notoriously dirty drug from a pharmacological standpoint. Its biggest issue is that it's a potent inhibitor of the cytochrome P450 enzyme system in the liver.
The body's main drug metabolism system.
Right. Cimetidine basically clogs up the garbage disposal. So if a patient is taking other drugs that are cleared by that system, and there are many, like warfarin, theophylline, phenytoin, their levels can skyrocket to toxic ranges.
A huge potential for drug interactions.
Massive. And it also has endocrine side effects.
It has anti-androgenic effects.
It does. It can block testosterone receptors and inhibit the metabolism of estradiol. So in men, long-term use can lead to gynecomastia, breast development, and impotence.
Which is why the newer agents like famotidine, Pepcid are much preferred. They're cleaner.
Much cleaner. No significant CYP inhibition, no hormonal effects. It's a perfect example of how we refine drugs over generations to improve their safety profile.
Okay, now it's time for the main event, the nuclear option. The proton pump inhibitors, the PPIs, omeprazole, esomeprazole, lansoprazole, and all the others.
These drugs didn't just improve on the H2 blockers. They represented a complete paradigm shift in acid control.
Because they don't target one of the upstream signals?
They target the final common pathway. They go after the pump itself. It doesn't matter if the go signal came from histamine or gastrin or acetylcholine. If you break the pump, no acid gets out. Period.
The mechanism here is so elegant. Goodman and Gilman goes into great detail on a concept called ion trapping, and you have to understand this to see why these drugs are so targeted.
It's one of the most brilliant pieces of drug design in pharmacology. It all starts with the fact that PPIs are weak bases.
So you swallow the pill, which is enteric-coated to protect it from the stomach acid.
Right. It gets absorbed in the small intestine into the bloodstream, where the pH is a neutral 7.4. At that pH, the PPI molecule is uncharged. It's lipid-soluble.
And because it's uncharged and lipid-soluble, it can easily diffuse across cell
So it
membranes.
floats around the body, and it diffuses into all sorts of cells, including the parietal cell. And from there, it diffuses into that tiny hyperacidic space, the canaliculus.
Where the pH is around 1.0.
And that's where the magic happens.
Oh.
The moment that weak base enters an environment with a pH of 1, it instantly picks up a proton, it becomes protonated, ionized, it gains a positive charge.
And a charged molecule cannot cross a lipid membrane.
It's trapped. It wandered into the room easily, but now the door's locked and it can't get out. This ion trapping mechanism causes the drug to concentrate in the one place in the body where acid is being made.
So the concentration in the canaliculus becomes much higher than in the blood.
About 1,000 times higher. It's an incredible targeting mechanism that ensures the drug only acts where you want it to.
Okay, so it's trapped. Now what does it do?
That intense acidity does one more thing. It catalyzes a chemical rearrangement of the drug molecule itself. It converts the inactive prodrug into a highly reactive species called a sulfonamide.
And this sulfonamide is the active weapon.
It's the warhead. This reactive molecule then seeks out and attacks a specific part of the proton pump enzyme. It finds cysteine residues on the pump.
And it forms a covalent disulfide bond.
Covalent, that's the key word. This is not a temporary competitive blockade like an H2 blocker. This is a permanent, irreversible bond.
That pump is dead. It's been sabotaged.
It's completely and permanently inactivated. The only way the cell can secrete acid again is to synthesize a brand new pump protein from scratch, and that takes about 18 to 24 hours.
And this explains that classic pharmacology question, the mismatch between the drug's half-life and its duration of action.
Exactly. The PPI is cleared from the blood in about 90 minutes. It's a hit-and-run drug. But because it has permanently destroyed its target, the acid suppression lasts for over 24 hours.
But, and this is the biggest but, in their clinical use, this entire beautiful mechanism depends on the pumps being active and on membrane, right?
This is the single most common reason for PPI failure in the real world. A patient takes their own Brizol at bedtime on an empty stomach and then wonders why their heartburn is no better.
So explain why that timing is so wrong.
Remember those tubular vesicles? The storage depot where the pumps hide when they're resting?
Mm-hmm.
The PPI, even if it gets trapped in the canaliculus, cannot reach the cysteine residues on the pump if the pump is tucked away inside the cell. It can only bind to pumps that are actively working on the membrane.
So you have to lure the pumps out into the open first?
You have to. And the most powerful stimulus to get the pumps to the membrane is a meal. So the correct way to take a PPI is 30 to 60 minutes before your first meal of the day.
So the drug has time to get absorbed and concentrate in the canaliculus, and it's just sitting there waiting.
It's waiting in ambush.
Yeah.
Then you eat. The food stimulates acid secretion. The pumps all move to the membrane to get to work. And as soon as they open for business, bam, the activated drug is there to bind them and kill them.
And if you take it without food or hours after a meal?
The drug gets there, finds most of the pumps are in hiding, it gets cleared from the body, and you've wasted the dose. You might inhibit 10 or 20% of the pumps instead of 90%.
It also explains why it takes a few days to reach maximum effect.
Right, because at any given meal, only a fraction of your total pump population is active.
Yeah.
So it takes about 3 to 4 days of correct pre-meal dosing to sequentially knock out most of the pumps and achieve steady-state inhibition.
It's not an immediate relief drug like Tums. It's a systematically shut down the factory drug.
And that requires patient education, patience, and precision.
Okay, let's switch gears slightly. We've talked exhaustively about suppressing the acid. Let's talk about the other strategy, reinforcing the shield, the cytoprotective agents. First up, sucralfate.
The chemical Band-Aid. This is a really interesting drug. It's a complex of sucrose, sulfate, and aluminum hydroxide.
And its main feature is that it's selective. How does it find the ulcer?
It's all about electrical charge. In the acidic environment of the stomach, sucralfate polymerizes. It cross-links into this thick, viscous, sticky paste that is strongly negatively charged.
Okay.
Meanwhile, the ulcer crater, which is full of dead cells and exposed proteins like fibrinogen and albumin, has a net positive charge.
So opposites attract. It acts like a magnet sticking directly to the wound.
Precisely. It selectively binds to the ulcer base and forms a physical barrier that literally blocks acid, pepsin, and bile salts from getting to the damaged tissue.
So why don't we use it more often? It sounds great.
It's a major compliance issue. For it to work, the stomach needs to be empty and acidic, so you have to take it 4 times a day, before meals, and at bedtime. The pills are enormous, like horse pills. And because it's a sticky paste, it can bind up other drugs and prevent their absorption. It's just very inconvenient.
Okay, next up in this category, misoprostol.
Misoprostol is a synthetic version of prostaglandin E1. So this is a direct replacement therapy.
You're putting back the peacekeeping prostaglandins that the NSAIDs took away.
Exactly. Its mechanism is simple.
Yeah.
It binds to the EP3 receptor and does all the good things we talked about. More mucus, more bicarbonate, better blood flow, less acid. And it is clinically proven to be very effective at preventing NSAID-induced ulcers. But the side effect profile is very high. Prostaglandins stimulate smooth muscle contraction everywhere.
Which means the gut and the uterus.
Right. Significant abdominal cramping and diarrhea happen in up to 30% of patients, which limits its tolerability. And critically, it stimulates uterine contractions. It's an abortifacient.
So it's absolutely contraindicated in pregnancy.
Category X, absolutely forbidden. That risk profile means its use is pretty much restricted to very specific high-risk scenarios.
Finally, in this group, bismuth, like in Pepto-Bismol.
Bismuth is a fascinating old remedy that we're now understanding has multiple complex mechanisms. Yes, it can coat ulcers and erosions, providing a physical barrier. Yes, it can stimulate prostaglandin and bicarbonate secretion.
But the key feature, especially now, is its antimicrobial activity.
That's the game changer. It is directly toxic to H. pylori. It disrupts the bacterial cell wall synthesis and prevents the bug from adhering to the gastric epithelium.
Which is why it's now a cornerstone of the quadruple therapy regimen for H. pylori eradication.
Exactly.
Well, that's a perfect segue into our next section. Clinical integration. We have all the tools. Now, how do we use them to treat specific diseases? Let's start with peptic ulcer disease, and specifically the H. pylori story.
Right. We touched on the mechanism, but let's talk about the bug itself.
Yeah.
How does this bacterium survive in a vat of acid?
It seems impossible.
It's an evolutionary marvel. H. pylori is a gram-negative rod, and its first trick is that it doesn't live in the acid itself. It uses its flagella to burrow deep into that protective mucus layer to get close to the neutral cell surface.
But its real secret weapon is an enzyme, urease.
The urease enzyme is its life support system. It takes urea, which is present in gastric juices, and it hydrolyzes it into ammonia and carbon dioxide.
And ammonia is a strong base.
Exactly. The bacteria surrounds itself in a little cloud of ammonia that neutralizes the stomach acid in its immediate microenvironment. It creates its own personal pH-neutral force field.
It's walking around in a chemically generated spacesuit.
A perfect analogy. And once it's safe, it attaches to the epithelial cells and injects toxins that disrupt the cell junctions and trigger a massive inflammatory response, which is what ultimately causes the ulcer.
So the mantra for treatment is heal and eradicate. You have to kill the bug to cure the disease.
You have to. Standard triple therapy is a PPI plus 2 antibiotics, usually clarithromycin and amoxicillin.
Now here's the key pharmacological insight. Why is the PPI essential in that cocktail? Is it just to help the ulcer heal while the antibiotics work?
That's part of it, but it's not the main reason. The PPI is a crucial force multiplier for the antibiotics.
How so?
For two reasons. First, some antibiotics, like clarithromycin, are acid labile. They break down in a low pH environment. By raising the pH, the PPI protects the antibiotic and increases its concentration.
Okay, so it protects the weapon.
But more importantly, it makes the target more vulnerable. Most antibiotics, especially amoxicillin, which targets cell walls, only work on bacteria that are actively growing and dividing. In the harsh, acidic environment of the stomach, H. pylori can go into a dormant, stationary phase to protect itself.
So by raising the stomach pH with a PPI, you're tricking the bacteria into thinking things are safe?
You're lulling it into a false sense of security. It comes out of its dormant state and starts to replicate, and that's when the amoxicillin can kill it. By raising the pH, you dramatically lower the minimum inhibitory concentration, the MIC, of the antibiotic.
That is a brilliant piece of pharmacology. The PPI isn't just treating the ulcer, it's making the bacteria susceptible to the cure.
Without a PPI, the eradication rates for these regimens plummet. It is absolutely non-negotiable.
What about the other major cause of ulcers? NSAIDs. Say you have a patient with severe rheumatoid arthritis who cannot stop their NSAID.
The first choice, if their cardiovascular risk allows it, is to switch them to a more selective COX-2 inhibitor like celecoxib.
And if that's not an option?
Then you must add a protective agent. And for both healing an existing NSAID ulcer and preventing a future one, PPIs are superior to H2 blockers and even misoprostol, mainly because they're so much better tolerated.
Okay, let's shift to GRE. Gastroesophageal reflux disease. You have to be clear here. This is primarily a mechanical problem, not an acid overproduction problem.
That's right. The problem in GRD is a leaky valve, a transiently relaxing or incompetent lower esophageal sphincter, the LES. We don't really have good drugs to fix the valve itself.
So the strategy is to change the nature of the fluid that's refluxing. You make it less corrosive.
Exactly. If what comes up is pH 6 instead of pH 2, it causes far less damage to the esophagus.
And for this, PPIs are the undisputed champions.
For moderate to severe GERD, and especially for healing erosive esophagitis, where you can see physical burns on an endoscopy, PPIs are far superior to H2 blockers. We often even use an empiric PPI trial as a diagnostic tool.
Take this for 8 weeks. If your chest pain goes away, it was probably GERD.
A very common and effective strategy.
Let's touch on one more specific clinical scenario. Stress-related mucosal damage in the ICU.
We talked about the mechanism ischemia from shock or trauma, dropping the shield. In the ICU, any patient on a ventilator or with major burns or head trauma is considered high risk for a major GI bleed from these stress ulcers.
So prophylaxis is standard of care.
It is. We give these patients either IV H2 blockers or IV PPIs with the goal of keeping the intragastric pH above 4.0.
Why is 4.0 the magic number?
2 reasons. First, the digestive enzyme pepsin, which also damages tissue, is inactive at a pH above 4. And second, and this is a critical point for any GI bleed, acid and pepsin are fibrinolytic. They actively dissolve blood clots. If you have a bleeding ulcer and the stomach is acidic, the clot that's trying to form to plug the hole will just be digested away. You have to neutralize the acid to allow a stable clot to form and for hemostasis to occur.
Wow, so the acid isn't just causing the wound, it's preventing it from healing.
Precisely.
All right, this brings us to our final and in many ways most contentious section, the safety and long-term consequences of PPI use.
For a long time, we thought these were miracle drugs with virtually no side effects. We handed them out like candy. Now, the pendulum of opinion is definitely swinging back.
Let's go through the evidence, from the most plausible to the more debated. First up, infections.
This one has a very strong biological rationale. Stomach acid is a primitive but very effective part of our innate immune system. It sterilizes much of what we swallow.
It's the gatekeeper.
It's the gatekeeper. When you chronically suppress that acid, you lower the barrier to entry for pathogens.
And the big one here is Clostridioides difficile, or C. diff.
The link is very consistent across many studies. PPI use is associated with about a 2 to 3-fold increased risk of developing C. diff colitis and also an increased risk of recurrence.
And what about pneumonia?
Specifically hospital-acquired pneumonia. The theory is that with acid suppression, bacteria that wouldn't normally survive can colonize the stomach. Then tiny amounts of that bacteria-laden stomach content can be microaspirated into the lungs.
Okay, those seem pretty plausible. What about the nutrient absorption issues, vitamin B12?
This is also mechanistically sound. Vitamin B12 in our food is bound to dietary proteins. To absorb it, you first need acid and pepsin to cleave it off that protein. Only then can it bind to intrinsic factor for absorption later on.
So if you have no acid, you can't free the B12 from your food.
Correct. So long-term, multi-year PPI use can definitely lead to a gradual depletion of B12 stores. It's something we should be screening for in elderly patients on chronic therapy.
What about minerals? Calcium, magnesium?
Magnesium is a real one. We see rare but severe cases of hypomagnesemia in chronic PPI users, which can cause tetany and seizures. The mechanism isn't perfectly clear, but seems to involve inhibition of an active transport channel in the intestine. The calcium story is a bit more controversial.
This is where we get into the bone fracture debate.
Right. The FDA has a warning about an increased risk of hip, wrist, and spine fractures with long-term PPI use. The proposed mechanism is that you need acid to solubilize and absorb dietary calcium. No acid, less calcium absorption, which leads to secondary hyperparathyroidism, which then leaches calcium from the bones.
But the data for this is all observational, isn't it?
It is. It's from large epidemiological studies. And the problem is confounding. Who takes PPIs long-term? Often it's older, sicker patients who may have other risk factors for osteoporosis anyway.
So it's an association, but causation is not definitively proven.
Correct. The same caution applies to the links with dementia and chronic kidney disease.
This is the stuff you see in newspaper headlines.
Yes. And the evidence here is even weaker. Again, large database studies show a statistical correlation. But is it the drug causing dementia? Or is it that people with underlying vascular disease that might lead to dementia also have more reflux and are therefore more likely to be on a PPI? We just don't know.
So the takeaway for a clinician or a learner is to be aware of these associations, but not to panic, and to practice good stewardship.
Exactly. The trend now is all about deprescribing. If a patient doesn't have a strong indication like Barrett's esophagus or a history of bleeding ulcers, you should try to get them off the PPI, or at least down to the lowest effective dose.
And when you do decide to stop the drug, you have to be very careful about the rebound.
This is a critical clinical pearl. If you have a patient on a high-dose PPI for several months and you stop it cold turkey, they will often feel terrible.
Why? What's happening?
Remember that chronic acid suppression leads to high levels of gastrin, hypergastrinemia.
Right, the body is screaming for more acid to compensate.
Well, gastrin is also a trophic hormone for the ECL cells. Chronic high gastrin leads to ECL cell hyperplasia. You actually grow more of the cells that make histamine.
So you've built a bigger histamine factory?
A much bigger factory. Then, when you suddenly stop the PPI, all the pumps wake up and they are hit with a tidal wave of stimulation from this hyperplastic system. You get a massive rebound acid hypersecretion that is often much worse than their original symptoms.
Which, of course, convinces the patient, oh my gosh, my disease is back with a vengeance. I need that pill forever.
It creates a vicious cycle of dependency. The key is to taper the drug slowly. Cut the dose in half, then go to every other day, maybe switch to an H2 blocker for a while to ease them off.
That's a great point. Final thought for me, and it's a bit more speculative, the microbiome. We are fundamentally altering the chemical environment of the upper GI tract for years on end. What does that do to the ecology of the gut?
That is the million-dollar question right now. We are seeing clear evidence that chronic PPI use alters the gut microbiome. Specifically, we see what's called an oralization of the gut flora.
Meaning bacteria that normally live in the mouth.
Like Streptococcus species, can now survive the passage through the stomach because the acid barrier is gone. They then take up residence in the small intestine, a place they don't belong.
And that could contribute to things like small intestinal bacterial overgrowth or SIBO?
It can.
Wow.
It causes a state of dysbiosis. And we are only just beginning to scratch the surface of how the gut microbiome influences everything from our immune system to our mood to our metabolism. By profoundly changing the pH, we are running a long-term, uncontrolled experiment on that ecosystem.
It's a very sobering reminder that there are no isolated interventions in the body. You pull one lever in the stomach, and you might be turning gears in the bones, the kidneys, the brain, and the bacterial colonies living inside you.
Pharmacology is always the manipulation of a complex, interconnected system. There are always downstream consequences.
That is a perfect place to wrap this up. We've journeyed from the million-fold ion gradient of a single parietal cell all the way to the global ecology of the gut microbiome.
It's quite a trip.
For anyone listening, if you really want to see the detailed signaling diagrams, the chemical structures of these drugs, and the clinical trial data, please go back to the source texts.
Katzone, Chapter 62, for that clear clinical scaffolding, and Goodman and Gilman, Chapter 49, to really dig into the molecular weeds, look at the figures, trace the pathways we've discussed. It will make the pharmacology stick.
Thanks for listening to The Deep Dive.